All right, hi everyone. It's great to be here. Today, I am going to talk to you about two of my favorite things. So neuropsychology and biomarkers, actually three of my favorite things: neuropsychology, biomarkers, and chronic traumatic encephalopathy. So I'm really going to focus on how neuropsychology and biomarkers intersect for the clinical diagnosis of neurodegenerative diseases and where we are at with that in terms of CTE. So this talk will have definitely more of a clinical lean to it. I don't have any disclosures. So as I was just mentioning, the primary goals that I'm hoping to get across and for everyone to walk away with from today is how do we currently use both neuropsychology and biomarkers to come up with accurate diagnoses of neurodegenerative diseases during life. And also, where do we stand with using these tools to diagnose CTE during life? And we'll get into kind of briefly what CTE is, but I won't spend too much time on it given others have focused on that. But I will talk about what do we know about the neuropsychology profile of CTE and what do we know about current biomarkers for CTE. So before we get started, I think it's important for everyone to know what is a neuropsychologist. And here's a definition I like to use. I'll just start off by reading the beginning of it. But quote, a clinical neuropsychologist is a professional within the field of psychology with special expertise in the applied science of brain behavior relationships. Clinical neuropsychologists use this knowledge in the assessment, diagnosis, treatment, and/or rehabilitation of patients across the lifespan with neurological, medical, neurodevelopmental, and psychiatric conditions, as well as other cognitive and learning disorders. So I'll stop there. But really, in its simplest form, a neuropsychologist is someone who studies brain behavior relationships. They provide diagnosis to people who are having different types of behavioral disturbances, and they help with treatment coordination and treatment management as well. And it kind of boils down to three or four things that neuropsychology can do. So the first thing that I like to think of is that neuropsychology can objectively identify whether or not there's actual impairment in thinking and memory. So many people have concerns about their thinking, have concerns about their memory, but neuropsychology can objectively evaluate those concerns to see if the brain is functioning like it's supposed to. It will also allow us to identify the severity of those impairments, right? So it'll tell us, is there impairment present? And then how severe are those impairments? It allows us to monitor cognitive function or cognitive decline over time, which is really important for treatment recommendations and treatment planning. Is the disease progressing? Is it staying stable, or is it getting better? Different disorders, different diseases also produce different types of profiles. And therefore, we can look at the profiles of scores and get an idea of what might be causing these thinking and memory problems. And then finally, and one of the things that I've been finding to be most powerful in neuropsychology, particularly in the setting of CT, is psychoeducation, or educating the patient on their thinking and memory, educating the patient on these different diseases and what we know and don't know as well. And then it can also inform, as I've been mentioning, kind of treatment recommendations. So what kind of recommendations are there for support groups if they need psychiatric care? How do we develop compensatory strategies to deal with these thinking and memory problems? Or what do we do to help this person with their activities of daily living? How do we advise on driving? So these are all the different roles that neuropsychology can play. I think it's really important to flush out how cognitive screening is different from a neuropsychological evaluation. So cognitive screening takes place most often in the setting of kind of a primary care setting, right? Or a kind of a point of care setting. Cognitive screenings do a really great job of identifying potential concerns. They do a good job of monitoring thinking and memory over time, but they have quite a bit of limitations, right? It's just a screening tool. There's a lot of false positives. There's a lot of false negatives. People who are highly educated can do quite well on these tests, so it's going to miss these subtle impairments. And so really, we like to use these screening measures just to get a quick insight into someone's thinking and memory to help us determine, do we need to refer this person for more comprehensive evaluation? It does not require a neuropsychologist. Like I said, a lot of times primary cares will do this or other similar types of conditions. In contrast, a neuropsychological evaluation is designed to assess several domains of thinking. So we try to get an idea of a person's intellectual function, and depending on the type of exam, that can range from a really comprehensive exam to kind of just a brief measure to get an idea of where this person was before their injury, before their disease. But we look at memory, we look at learning, executive functions, attention, language, visual spatial abilities. We try to incorporate effort into every evaluation, right? Effort, in order to accurately interpret these scores, we need to be sure the person in front of you is giving their best effort. Some people might not give their best effort for various reasons. It could be intentional for secondary gain, or it could be due to things like depression. People who have depression, hard to get going, but we need to know, what's this person's effort like? And we also screen for psychopathology, so depression, anxiety, impulsivity, other types of psychiatric symptoms, because those can also affect our thinking and memory, and be a consequence of some of these neurodegenerative diseases. And we take and we administer all of these tests because we're trying to get an idea of how the brain is functioning, right? And so when we sit someone down in a quiet room, is the brain functioning like it's supposed to? And so we're trying to really, for example, if we're trying to look at memory, we're testing the ability of the hippocampus to kind of retain information. And so that's what we're ultimately getting. Is there something going wrong with the brain that's causing some of these thinking and memory problems? So what we do once you administer the test, you then generate raw scores, right? And and then you take those raw scores and you convert them to standardized scores. And so these standardized scores are generated using normative data. And so there's a lot of different published normative data out there, but the principle of them is that these are data of people who are the same age, same sex, same education, or other factors to the person in front of you who have no thinking and memory problems. And you're comparing your patient to this normative data set. When selecting normative data, the general guideline is you pick the data that's most appropriate for the person in front of you. Now, as we'll mention later, the norming practices and even the tests themselves have a lot of limitations. They're quite outdated. They're developed in white populations. They lack cultural sensitivity, and that's really important as a field for the field to address. And again, I'll mention this briefly at the end as well. But then once you're able to compare them to the normative data, then you can start to identify impairments. And you can see what domains or what tests are most affected. And you can see how these impairments or how their performances might translate to impacting that person's daily function. And then we combine these test scores and their test performance with our clinical interview. And so the clinical interview plus the test scores is what we use to come up with our first diagnosis of the clinical syndrome of this person. All right, and we never rely on just one piece of data. It's kind of the full story that really informs our diagnosis. And when I say clinical syndrome, this is what I'm referring to. Right, so at this point, I'm not talking about etiology. I'm not talking about Alzheimer's disease, CT. I'm just talking about what this person looks like syndromally. And so This ranges from being completely cognitively normal, right? Someone, maybe they have some subtle concerns, but they test out completely normal on testing. So we would bin them more in cognitively normal bin. But then it's also mild cognitive impairment, right? So regardless of the cause, does this person have what we call MCI? So that's when they have concerns for their memory and thinking. And now they also have impairment on our neuropsychological testing. And then the third stage is dementia. So they have concerns for their memory and thinking. They have impairment, usually multi-domain impairment on testing, but now they're also having trouble functioning in their daily life. So they're having trouble driving, managing their finances. If they're working, they're making mistakes. So there's functional difficulties now. And while we like to bin people diagnostically, right, there's a continuum. And so it's really also about moving to kind of describing what this person looks like as well. But I think for the purpose of this talk, this is kind of how we bin them based on syndromes. Is this person normal, cognitively normal? Do they have MCI? And do they have dementia? Okay. And we can get this information just based on our interview and based on our testing. Now we can also use the neuropsychological test scores, though, to inform etiology. Okay, so like I said, different diseases and disorders can produce different types of profiles or patterns on testing. So, for example, in Alzheimer's disease, you typically get, in kind of how it's been classically described, an amnestic profile. They have trouble with semantic fluency. They have trouble with confrontation naming. And so if you see these types of patterns on testing plus other data, so is this person older? Do they describe worsening memory? Then you're kind of leaning towards an Alzheimer's disease type of etiology. And this would map on to what we also know about the tau distribution of AD, right? Where it starts to begin more in the medial temporal lobes, right? The hippocampus and entorhinal cortices, which are all really important for memory. And that's why we, again, in the classical descriptions of AD, we see memory as the initial symptom. But really in the last several years, we know that a good proportion of Alzheimer's disease is non-amnestic, right? Or actually about 20 to 25% have an initial presentation that's dysexecutive or language or non-memory in general. And this might be because of where the tau starts, right? Maybe there's differences in the regional location of tau or variants of where the tau starts. Or it could also be to the presence of comorbid disease. Something we focused on a lot is white matter injury or white matter loss. And maybe that's contributing to these different variants of Alzheimer's disease. But I bring this up because that's why the field has really moved towards defining Alzheimer's disease by using biomarkers and by its underlying pathophysiological processes here. So this was a paper I'm sure most of you have seen in 2018 that really changes the framework of how we think about and diagnose Alzheimer's disease. And it really does and really integrates biomarkers into the picture to pick up on these disease-specific proteins. So that way, when you do have kind of an atypical presentation, like an executive presentation that could be due to AD, you can use biomarkers to help inform, is this AD that's resulting in a dysexecutive variant? And so what I'm going to focus on for this talk in terms of biomarkers is the more specific biomarkers. So that is your amyloid beta biomarkers that accumulate outside the cells, but also your phosphorylated tau biomarkers that accumulate inside of the cells. The tau one is common to both AD and CTE, whereas amyloid is more central to Alzheimer's disease. And so we have biomarkers that are quite good at picking up on these proteins. So we have an amyloid PET scans. They've had tracers approved by the FDA since at least 2012. And there's several different tracers that are approved for use for AD. And so here it's showing you differences between an amyloid negative and amyloid positive scans, right? So an amyloid, what you're looking for in interpreting these scans is differentiation between the white and gray matter of the brain. So in the top row, you see an amyloid negative scan, and if you look at through the sequences, you can clearly see the white matter and the gray matter of the brain throughout. In the bottom row, which is amyloid positive, the tracers being, there's uptake of the tracer into the cortical gray matter, and therefore you lose that differentiation between the white and gray matter, and here's a clearly positive scan. Now there's also quantitation of this as in addition to visual reads as well. Perhaps a little bit newer to the scene is tau PET, and there's been many what we refer to as first generation tau tracers, and these include things like FDDNP, fluorotaucipir, and so on, and these are all developed to detect tau associated with Alzheimer's disease. Fluorotaucipir has the best affinity to AD tau, so 3R, 4R, and actually that was not so long ago approved by the FDA for Alzheimer's disease as well. But what we know about these tracers is it has pretty low binding affinity to non-AD neurodegenerative diseases. So they work quite well in AD, but not so much in our other, FTLDs, PSP type diseases. There's also second generation tracers, which I'm going to talk about during this lecture too, including MK6240 and PI2620. These were developed to improve upon some of the off-target binding we see with things like fluorotaucipir, specifically kind of in the hippocampus, and really to kind of improve the binding selectivity and the overall pharmacokinetics. So we can use both amyloid and tau PET plus neuropsychology to give us the best chance of the most accurate diagnosis and as well as help with give us the best chance to help treat the person in front of us. And so I'm going to give you a case example of how these biomarkers and how neuropsychology kind of come together in a clinic setting. So I'm going to give you a case from the Memory and Aging Clinic that Dr. Mez and myself run at Boston Medical Center. So this is who I'll refer to as Mr. A. So he's a 63-year-old man, right-handed man who has 12 years of education. So he has a history of coronary artery disease. He's on a statin for medications. He doesn't have much in the way of psychiatric diagnoses or treatment. In terms of family history, he does have his mother was diagnosed with late onset Alzheimer's disease, but otherwise it was negative for family history. So this patient described onset of both memory and trouble with word retrieval beginning in his late 50s. And this was endorsed by both him and supported by his wife. And so specifically described kind of he would hesitate when talking. He would forget conversations he had kind of minutes ago. He's misplacing his wallet, his keys, and kind of some of his other personal belongings. He would repeat himself. You'd be talking to him and you'd kind of easily get distracted and lose his train of thought and have trouble kind of participating in the conversation. And these really kind of progressed over time. He also began to have functional problems. So a lot of these thinking memory problems had to result in him retiring from work. He was starting to get lost while driving. And he was quite dependent on many instrumental activities of daily living. So the FAQ is kind of a measure out of 30 that assesses IADLs, and he had a 16. So, and we think of a 9 as being elevated. So it was definitely elevated. And this is all kind of accumulated to lead to quite a bit of irritability on him and frustration. So Mr. A, he had a neurological exam that was normal, so no kind of Parkinsonism or other motor signs or symptoms. We did, there was lab work done to look at reversible causes of dementia, so things like vitamin B12 deficiency, abnormal thyroid hormones, and those were all within normal limits, so we can rule out those as contributing here. And so the first question when you think about if you're a clinician or a doctor is you have this history, and you have this person in front of you, and you want to know, should I refer this person to neuropsychology? And so the way I like to think about is this an appropriate neuropsychology referral? One is looking at their age. So clearly this person's an older individual. They're in the age range of when you would expect certain neurodegenerative diseases to begin. So it kind of checks the box of age. If this was someone who was in their 30s or 20s, and you want to get a memory workup, that's probably not appropriate, depending on kind of different circumstances. The primary concerns are cognitive, and I bring this up, right, because a lot of these neurodegenerative diseases can have neuropsychiatric phenotypes. But if there's really unstable depression, if there's really unstable anxiety or overwhelming psychiatric symptoms going on, it's really hard for us to tease apart what's psychiatric versus what's neurodegenerative disease. And so I like to see the person being stable psychiatrically before we do neuropsychological testing in order to get an optimal differential diagnosis. And that kind of leads me to my third point too, is if there's no unstable condition, no unstable medical conditions that would really interfere with neuropsych testing or diagnosing. So another example is active substance use. If there's active substance use, again, I would say to refrain from sending to neuropsychology, because again, it's really hard for us to give a accurate diagnosis when that person drinking or using drugs actively. And the fourth one, it's not always available. It's ideal, but of course, I would say that if there's not an informant or someone who can speak on this person's symptoms, doesn't mean you shouldn't refer or send to neuropsychology. But it is ideal to have someone. And I say that because as you progress in the disease, their person can have a loss of insight. So we need someone there who's disease-free, right? And then there's also other reasons. It's just really good to get a second opinion, someone who knows that person from their baseline to see how they changed over time. And so if all of these things are met, generally you can think of a neuropsychologist being happy or sick, if green means sick. So, all right, so going back to this case, right? So this is a 63-year-old, memory problems, word finding retrieval, good referral for neuropsychology, nothing in the way of unstable medical conditions. So what are the results? So let's start with our, in this case, this is the rat, what I'm showing you, very kind of quick and dirty way to get an idea of what this person's intellectual functioning was like prior to disease, right? So this is a measure of someone's verbal abilities. We think about our verbal abilities as crystallized intelligence and tend to hang on in the presence of disease. And so they got a 52, and this is their standard score. So average is 100, standard deviation of 115. So this person's on the higher end of the average range. So pretty bright person. We look at effort. So the test of memory malingering, or TOM, is a really quick measure. Actually, it's not so quick, but it's a measure of someone's ability to put forth effort. It has its limitations. It's at a 50. We look at trial 2, and this person got a 46 out of 50. We tend to think of below 45 as failing. So we don't have much in the way of questionable effort here. Learning and memory. So we look at learning and memory in a few different ways. So first is verbal, and this is, I'm showing you all verbal learning and memory here. And so the first one, craft memory, is learning and memory for a story. And the second one, NAB list learning, is learning and memory for a word list. Okay, so typically what we see is people do better on memory for stories versus word lists because there's structure, there's context, there's clues to the story. Whereas a list learning, you have this list of words and it's kind of up to you to organize them and learn them and then remember them. So here you don't see much of a pattern. This person's pretty impaired across the board, learning and memory. In fact, there's rapid forgetfulness going on. If you just look at the list learning, so the word list is 12 words. So this is a sum of 3 trials. So across all 3 trials, they only got 12. So pretty poor learning. Out of the 12 words, they recalled 0 after a long delay. Okay, so can't generate any of the words they learned. When you give them a longer list of words that were not on that original list, they can only recognize 7 out of 12, and they're pretty much saying yes to everything because they don't know, as indicated by the false alarms. We'll also look at visual learning and memory, the Benson here. And you can see here that they had trouble copying the figure, and then they recalled 0 of the figure after a delay period, so very impaired. The judgment of line orientation, or the JOLO, is a measure of kind of complex visual perceptual, visual spatial abilities. And these are T-scores, so an average is 50, standard deviation of 10, and you can see that they're in the average range. In general, we tend to think of 1.5, 1 to 1.5 standard deviations as being away from the mean, as being impaired. Continuing on, we look at language. So this person, we gave 2 measures of semantic fluency, so animals and vegetables. How quickly can you say as many animals as you can or as many vegetables as you can in 60 seconds, right? How many can you get? These are really rehearsed categories, right? You learn animals and vegetables from when you were a kid. So you should be able to get these words out quickly. And in Alzheimer's disease, that's or other dementias too, that becomes challenging. And you can see that they're quite impaired here. However, on a test of confrontation naming, so showing them common objects, and asking them to name them, again, a test that's usually quite impaired in Alzheimer's disease, that was hanging on, and that was within normal limits. Looking at executive function, so I'm sure many have heard of Trails B, where you're connecting letters and numbers in order as fast as you can. This kind of ability to kind of shift sets, go between different types of categories, and that was impaired. NAB mazes is just like what it sounds like. You're completing a bunch of different mazes and increasing complexity. It's kind of testing that person planning foresight, and that was impaired. FNL is a measure of phonemic fluency. So instead of asking that person to retrieve words from a certain category, it's from a certain letter. So it's less drawing on kind of that semantic memory. And you can see this person is impaired. I'm not impaired, I'm sorry, within normal limits. Attention, so the basic attention, well within normal limits, or not well, it was within normal limits. Trail making test A, so just kind of a quick motor task or visual scanning task, connecting numbers in order as fast as you can, was impaired. Symbol digit modalities was also impaired. That's matching letters and numbers as fast as you can. I'm sorry, letters to symbols as fast as you can. So if I had to summarize, right? So at this point, we know this person's history. We know this person's testing results. And so we're now at the place to stage this person in terms of their syndrome, right? So it's pretty clear he's not cognitively normal. And so the question is this person MCI or dementia? Based on his testing, right, he has multi-domain impairments. They're pretty severe impairments, but he's also having functioning. Remember, he retired from work. He's getting lost while driving. So I think he's in this bin of being demented. But now the question is, what's causing the dementia? What is the etiology? And now we bring in biomarkers to help us come up with a diagnosis of the etiology. And so this is this person's structural MRI that everyone gets in the clinic. And so you can see this coronal sequence, and then on the right is the axial sequence. And you can see for this person here, looking at the coronal, they did have some hippocampal atrophy, right? Particularly right here, you can see my cursor. Some hippocampal and cortical, and as well as cortical atrophy, particularly kind of more posterior, as you can see on the axial. He also had here an infarct or a lacune here as well. So there was some shrinkage or atrophy to the brain. Now, we were fortunate also to get an amyloid PET scan on this person. And the amyloid PET scan, if you look at this, right, so remember, we're looking for differentiation between the white and the gray matter. Okay, so if you look at these sequences, you really kind of lose that differentiation, right? So it's pretty obvious that this is a positive scan. So this scan is consistent with the presence of moderate to severe neuritic amyloid plaques in the brain. Now, the other protein we see in Alzheimer's disease is tau. And so this person was also able to get through our center an MK6240 PET scan. So again, this is an experimental tracer, meaning it's not approved by the FDA, but you can see, right, that it lights up. Really, like even here, if you look at where my cursor is, it's actually translucent because of how intense the signal is. And these are regions that you would expect for an Alzheimer's disease distribution of tau. And you can see up here, you have medial temporal lobe involvement. And then you can see back here, you have more posterior involvement of tau throughout the brain. So this is a lot of tau burden in this individual who's also amyloid positive. So what are our conclusions? So regardless of the biomarkers, the neuropsychological profile allow us to tell us how severe things are right now, and they look pretty severe. We're pretty concerned about this person's functioning. We need to put kind of things in place to help this person. But I would say that even after the neuropsych testing, it wasn't exactly clear what was causing it, right? The family history was remarkable for late onset Alzheimer's disease, but the person was 63. It's kind of on the younger side for Alzheimer's disease. I mean, it certainly happens and can happen quite often, but the symptoms also start in that person's 50s, right? So at that age, you're thinking more of a frontotemporal dementia. So the age kind of throws you off a little bit, especially when the age began. And the neuropsych testing, it didn't really help that much in terms of the etiology. And it didn't help that much because everything was impaired, right? It told us how severe things were, but there wasn't much of a profile because of how impaired everything was. So you're walking away kind of with differentials of Alzheimer's disease. Perhaps, the frontotemporal dementia, the age was perhaps one of the only supporting things. They didn't have that kind of social disinhibition. They did have a lot of language complaints and language impairments, but it was still unclear. But then the biomarker profile, right, was pretty classic Alzheimer's disease. On MRI, you had hippocampal atrophy, you had positive amyloid, and then you had that positive tau PET scan and the distribution you expect for Alzheimer's disease. And that's really important to know, right? Because if it determines whether or not you're going to prescribe a certain medication for this person or not, if it's Alzheimer's disease versus a frontotemporal dementia. And even kind of thinking about more recently to the expedited FDA approval for lecanemab, knowing Alzheimer's disease is really important for who's appropriate. Again, based on the clinical trial of that study, this person's probably not appropriate because they're too far along, but still, this helped clarify a lot in terms of etiology. So shifting gears a little bit to CTE. So we know those biomarkers work really well in Alzheimer's disease. We know the neuropsychological profile of Alzheimer's disease. Let's use this same approach to see if we can come up with an accurate in vivo diagnosis for chronic traumatic encephalopathy, or CTE, okay? And that's what we've been trying to do, for better or for worse. So really briefly, what is CTE? You've seen this before, I think many of you, but I think it's important just to reiterate here because this is what we're trying to capture with our biomarkers. So on the right here is the pathognomonic lesion of CTE. You have the tau in brown, that it tends to accumulate around the blood vessels, the white circle there, and it tends to accumulate at the bottom of the folds of the brain. There's 4 stages of CTE, stage 1 through 4. Stage 1, it starts off as kind of patchy focal deposits in the frontal cortex, and then spreading to stage 2 in adjacent cortices. And then stage 3 and 4 is more, the medial temporal lobe becomes involved and becomes more widespread. Now, interestingly, and complicating things further, is there's an increasingly variant, it seems like, where there's more of a kind of a cortical sparing of CT. But that's for another talk, not by me. So CTE, what's it caused by in part? It's repetitive head impacts. So this is nice work that Dr. Mez has presented at this lecture series as well, where he shows a direct relationship between the number of years you are exposed to repetitive head impacts from football and the odds of developing or having CTE, as well as the odds of developing severe CTE or CTE severity. So through the neuropathology, we've learned quite a bit about what this disease looks like in the brain after someone passes. We've learned quite a bit what the risk factor is for this disease, but we're still not able to diagnose this accurately after death. I think we have pretty good, with all the data we've collected, I think we can pretty much rule out everything else and kind of can land on CT, but we still don't have that biomarker or that profile that kind of points to CT like we do for Alzheimer's disease. We do have new and revised updated clinical research criteria for the diagnosis of CTE, and these were published in 2021. I'm not going to get into them to detail, but what it involves is having substantial exposure to repetitive head impacts, having the presence of core clinical features. So these include cognitive impairment and/or neurobehavioral dysregulation. So impairment specifically in memory or specifically in executive function, as well as neurobehavioral dysregulation. So kind of a lot of impulsivity, short fuse, rage. The cognitive impairment, again, a different talk, but the cognitive impairment seems to be closely tied to the tau of CTE. We see some signal with the tau of CTE and neurobehavioral dysregulation, but it's a lot weaker. And really the cause of this dysregulation seems to be quite elusive. Could it be these people are more aggressive to begin with and it gets worse with TBIs, it gets worse with age? Could it be that repetitive TBIs lead to multiple different pathologies, non-CT related, for example, white matter, that cause some of these? So this is something we're really trying to figure out. But the cognitive impairment is quite strongly tied to the tau in some of our data. I do like to emphasize that we don't use these in the clinic yet, in part because we don't know how reliable or how valid they are. They were published in 2021. We're doing reliability and validity studies now. And also because a lot of these things were informed by next of kin. So these were mostly informed through our brain bank, where someone dies and then we talk to a loved one and we get a kind of history of that person's symptoms. So it does not have the benefit of prospective objective assessments, which is my next point. So we've been working on addressing some of these knowledge gaps and these limitations through the Diagnose CT research project. So this is a study we recently published. Actually, one point where I was going with that too is the episodic memory and the executive function, particularly, again, are based on, a lot of it's based on the informant's report of these symptoms, absent or present. We don't know what the neuropsychological profile is because we don't have that prospective data. And that's what some of the Diagnose CT research project can address. And so this study was accepted for publication and is now in press at Alzheimer's Research Therapy. But this was a study on the neuropsychological profile of former football players from the Diagnose CTE study. And so the Diagnose CTE study includes a group of 120 former NFL players, 60 former college players, and then a control group. That control group is defined by people who did not have symptoms and did not have repetitive head impacts, right? And all of these three groups completed various biomarker exams, various clinical exams, neuropsychological testing, kind of as a very intensive evaluation. I'm not going to focus on the follow-up because I'm not presenting any of that data, but they did have a follow-up that was moved to remote or virtual because of COVID, and it was a 4-year follow-up. What we did for our study was to look at we wanted to look at the neuropsychological profile of the football players using the test administered. So a really important kind of methodological point I want to make here is that you have the football groups who were recruited based on exposure to repetitive head impacts, and then you have a control group recruited based on both repetitive head impact and symptoms. They had to have no symptoms. So we intentionally did not compare the football to controls because the controls are required to have no symptoms, and therefore it could artificially kind of bias our results in a way that might not be accurate. So we really just focused on the football players and describing their performance. And so this was the neuropsychological battery. I won't get into this in a lot of detail because I just presented all those tests I just presented are more or less what we give and diagnose. Everything in our center is relatively more or less harmonized. So I just walked through a lot of these tests with you. So we took the sample and we excluded people for missing data on the neuropsych tests. We also, like I mentioned, had several validity tests, so effort tests, and we excluded people who had suboptimal performance on 2 of those 3 validity tests. So that way we can rule out any concern that some of these scores, or attenuate concerns that some of these scores are low because of poor effort. And again, this is more kind of nuance for a different conversation, but it's really important in this sample where there's a lot of litigation going on to make sure we measure performance validity. We defined impairment by a t-score of less than 35 or less. So this is 1.5 standard deviations below the normative mean. And we also were quite conservative in defining how a domain was impaired. We said that 2 tests in a domain had to be impaired in order for that domain to be impaired. And we really focused on grouping the football players together because we actually didn't see much difference between the college and professional football players. And so here's our sample. So we had 170 football players after we excluded for some missingness. They were about 58 years old. The former professional were a little bit older than the college players. As you might imagine, they all played football in college, so they're highly educated. About 32% were Black or African American. Their body mass index was on average about 33, and the former college were actually had a little bit of a higher BMI than the former professional players. So the study I find is informative, but there's actually, it's pretty straightforward story. There's not a lot of nuances to it. And what we found was that the impairment rates were highest for episodic memory. And in particular, 44.7%, so about 20% were impaired in memory, right? According to our definition of 2+ tests being impaired. But if you just look at long delay recall of words, one of our more sensitive tests to memory, and for hippocampal function, almost 45% were impaired on that test. So it's quite high. We had better visual memory versus verbal. What was a surprising finding that executive function was not as impaired as we thought. You know, if we think about executive functions being controlled by the frontal lobe, pathology starting in the frontal lobe and CTE, we might think this would be higher. But about 15% had impaired executive function, most commonly on Trails B, where about 21% were impaired. Other tests, Trails making A was about 20% or 19% were impaired. Some of our language tests, so the naming, the semantic fluency, those had relatively higher rates of impairments as well. But overall, the take-home message of this story, of this study, was really the high rates of impairment in memory. And this makes our job as neuropsychologists really hard, right? Because that's what we see in Alzheimer's disease. So now we have this group of players who have a profile characterized by impaired memory. So how do we differentiate this from Alzheimer's disease? And here's a case example to kind of highlight this differential diagnosis dilemma. So this is actually a case from our brain bank. So this is a person who had 16 years of football play, began to play at 14, played 9 years in the NFL. He was a wide receiver, cornerback, and kick returner, estimated to have about 500 concussions. So in his mid-60s, he retired as a construction and sales manager and he developed some memory impairment, as well as executive dysfunction and trouble with navigation and driving. But he was still, pretty high functioning. He was still publishing novels, actually, despite some of these symptoms. His early 70s, his symptoms got worse. He began to have trouble with some of his activities of daily living. Around 72, 74, he went for a workup with a behavioral neurologist, as well as neuropsychologist and geriatric psychiatrist. And what this evaluation showed was global impairment in all domains, On the bottom here, you see an image of that shows actually shows us a cavum septum pellucidum, which is kind of hard to tell through these sequences, but something we have our eye on because we see it more commonly in the setting of repetitive TBIs. You see enlarged ventricles, you can see how big they are. You see kind of global clear atrophy as well as hippocampal atrophy. So this person was clinically diagnosed with having dementia due to Alzheimer's disease. His symptoms progressed and he kind of went on to become fully demented. And when we talked about this case at our consensus conferences for the brain bank, we also thought this was Alzheimer's disease. It was pretty classic. Now, this person also had a lot of exposure to repetitive head impacts from football, so we entertained the possibility of CTE, but really our conceptualization was Alzheimer's disease. But then you looked at the path and it was just CTE and had only sparse neuritic amyloid plaque. So no, not consistent with Alzheimer's disease. He had severe stage CTE. And so again, this really points to the need for biomarkers to help us with this case. This is someone classically meets, it presents as Alzheimer's disease, but has none in the brain at autopsy. This person would be diagnosed by most people with Alzheimer's disease during life. And again, this could have important treatment implications. So what do we know about biomarkers in CTE? How can they help us right now with this differential diagnosis? So we published, the team here published a nice MRI study. This was among our brain bank. We had anti-mortem MRIs that were collected through medical records. And we actually had our neuroradiology colleagues at BMC visually rate patterns of atrophy in people who had autopsy confirmed CTE versus people who had normal cognition from our Alzheimer's Disease Research Center. And the pattern was there's more frontal temporal lobe atrophy in the brain donors with CTE compared to the normal cognition group. And an important null finding was a lack of effects for her parietal occipital lobe. So if you're thinking about Alzheimer's disease, you might think that would have been elevated if Alzheimer's disease was present, but it wasn't. So really kind of perhaps one way biomarkers can help us with CTE is if we see more of a frontal temporal atrophy pattern on MRI and perhaps sparing or less involved atrophy of the posterior lobes that could help us rule out Alzheimer's disease. But we can also look to our PET imaging agents. So there's been quite a bit of work on tau PET imaging in CTE. So early work focused on a tracer known as FDDMP, and really interest has waned entirely for this tracer in the broader field because of its lack of specificity and kind of off-target binding. But really the focus has been to date on fluortaucipir. And based on some of our work and others, we think there's possible utility for this in late-stage disease, but we don't think this is kind of the winner. This isn't going to really inform on the presence of CTE. And it's because there's a lot of off-target binding, particularly in key regions like the hippocampus. It's unclear if that binding in the brain is related to tau of CTE, or is it other types of general neurodegeneration changes it's binding to. And really what we see is the intensity of binding is quite low, even in kind of the cortex. So maybe some usefulness later on when there's kind of full-blown CTE, but in terms of kind of getting at stage 2, stage 3 CTE, or even kind of being accurate as possible with later stage disease CTE, it's questionable. A study we're running with collaboration with UCSF is something we call Find CTE. We're looking at the MK6240 tracer, which I mentioned earlier. So this is actually a proof of concept R21. It's based on some of autoradiography work out of Pittsburgh that showed in tissue that this tracer might have promise in human subjects. And so that's exactly what we're testing. So we're recruiting 30 former National Football League players, all symptomatic, so at high risk for having CTE, and then 10 same-age men without repetitive head impacts. And then we're also working with the Wisconsin Registry for Alzheimer's Prevention, where they have tons of data, MK6240 data on cognitively normal males. And we're using that data as another comparison. All these people are enrolling in UCSF, BU ADRC. They complete our ADRC exams. They get both amyloid and tau PET scans. And then we're also, through separate funds, recruiting AD participants as well as another comparison. So this is a little bit outdated. I presented this at AAIC in June of last year. But we have, at the time there was 18, but we're actually close to our recruitment goal of 30 now. And actually what's really cool is we have a couple of participants where we have longitudinal MK scans on. So instead of getting new players, we substituted to have these people come back and see, evaluate the tracer over time. So we recruited people between 45 and 74, about 56% reported being Black. These are all NFL players. The diagnosis were there's a nice distribution. There was 4 who tested out normal. And then there was about 8 who had MCI, and then another 4 who had dementia. An important thing to note is that all of these people had a negative amyloid PET. So right there, we can pretty confidently rule out the presence of Alzheimer's disease. And then we had 36 men as a comparison group from the Wisconsin, and they were about 66 years old, and they were very normal. They had almost a 30 on the MSC on average. So here's a case example of what our study is showing. So this is one man who was 60 to 64, who was Black, and you see he had 16 years of education, played 20 years of football, 7 in the NFL. He had hypertension, high cholesterol. He had some medications for these risk factors. He did not have much in the way in psychiatric diagnoses or treatment. He did report having really diffuse multi-domain cognitive difficulties, and they started in their mid to late 50s. So even with this history, we're kind of leaning away from Alzheimer's disease, given how early on it is. Not much in the way of mood and behavioral disturbances. I'm not going to go through all of this testing, but in brief, this person was really quite impaired, global impairments. But really importantly, this person also failed his effort testing. For reasons that are unclear, unlikely to be intentional, I think there's cognitive impairment here, but it does kind of cloud the picture on how severe that impairment is due to that. Did have severe symptoms of anxiety. Another kind of complicated part of this picture is that an informant who, I'm not sure how well the relationship was, but they largely denied difficulties of this person. Either way, when we considered all the data at our consensus conference, we thought at least this person had mild cognitive impairment. We looked at the biomarkers. This is the structural MRI findings. So you can see there is some cortical atrophy, but the hippocampus looked pretty good. Like, this is the only sequence I could find a little bit of space for the hippocampus, but even here it looks good. Maybe a tiny interior cavum septum pellucidum. But then there is kind of striking vascular disease, right? So we can't rule this out as a contributing factor. Then we look at the tau scan. So this is one of our better examples of our tau scan, which should be telling. So this is a W map. So this is the general SUVR map, what's produced from the tau scan. The W map factors in the Wisconsin control. So it's essentially a Z-score that's standardized to that controls. And you can see that there is signal in the medial temporal lobe here, and there is signal in the superior frontal cortex here as well. But that signal, it's relatively weak, right? If you think about that AD scan I showed you a little while ago, it's nowhere near that intense, right? But we do see it, and the medial temporal lobe combined with the frontal temporal signal, I think is consistent with what you might see in something like CTE. Amyloid PET scan is shown here. We read it to be negative. Again, if you look through the brain, you can clearly see the white matter, gray matter differentiation. So in this case, Alzheimer's disease, right? So he had clear memory impairment. Memory was the predominant presentation of what was described. But the young age kind of drew us away from that. But then it brings you into frontotemporal lobar degeneration. specifically with his age and these symptoms beginning. But he didn't really describe having these classic symptoms you associate with an FTLD. What about PART? Or specifically when we see that signal of tau in the medial temporal lobes, could that be primary age-related tauopathy? I doubt it. He's pretty young, right? It's not age-related tauopathy. Plus, when you combine the MTL signal with the frontal signal, I think that helps rule out PART. And then CTE, I think you rule out all of these other things, and really you're kind of left with, see, what else could this be? I don't know if, do I have it on here? I don't have it on here, but obviously vascular disease is contributing here. What is that vascular disease from his risk factor or other things? It's unclear. He has anxiety, depression, all of these things are factors, but in terms of a neurodegenerative disease, I think you're left with CTE. And we've had some other cases where you see this more focal medial temporal plus kind of superior frontal binding as well. So next step, we're recruiting more participants. We're getting AD participants. We're also trying out a new tracer called known as PI 2620 that has more better binding to, we're supposed to have better binding to 4R tauopathy. And with CT starting out perhaps as a 4R, it might be interesting to see what that shows. So I think as a conclusions, this talk really showed you how neuropsychology and biomarkers intersect and how they intersect to get us to the best, most accurate diagnosis of AD and ADRD, including CT as possible. I think with CT, we're currently at a place of a game of exclusions. If you can rule out everything else and you're left with only one thing left, I think that's where we stand right now. We still don't have that biomarker that says this is positive for a CT, but I think we are at a place where when you have enough data points to exclude other things, we are getting more confident on whether or not CT is there. But really the big question though to me is, we can easily rule out AD through a biomarkers because we have good biomarkers for AD. We don't have good biomarkers for FTLD. So often what you're left with is the CT versus FTLD. And that's those studies we need to do in order to see how those are specifically different in terms of their phenotypes. And I think we also need to kind of really rethink about kind of our tracer development and finding tracers that might be more specific to CTE. There's a lot of field-wide issues. Each of these bullets are their own talk, but really kind of carefully thinking through disclosure of amyloid PET results. These are, we're moving as a field towards everyone's getting these results back, even people who are cognitively normal. And you really need to kind of think through what that means. And people want these results, and it's really good and informative, and it's really good for recruitment and retention, but there's a lot to think about. A lot of these biomarkers are not accessible, they're not scalable. I'm really excited about plasma biomarkers to help address some of those issues. I've talked about it and mentioned it. These neuropsych tests, we really need to do a better job as a field. They're very culturally insensitive. That said, while they were developed in white populations, they still seem to pick up on impairment in underrepresented populations. But we need to do a better job of identifying appropriate norms, using norms appropriately, developing and just a better job of integrating these sociocultural factors in our conceptualizations. And with that, I will end and just thank everyone from the center for all of their contributions.
Great. Thank you so much, Mike, for doing this presentation.